In today's discussion of video at Medical Sciences, we're going to go into details of antidepressants for people with depression. We want to see what is depression in this video. Then we shall see the different mechanisms of antidepressants used to treat depression. We shall look at the indications of each, more indications of each, and the side effects and the mechanism of action of each drug. And we begin, we remind you to subscribe. Why do we tell you to subscribe? Is that whenever we release a video, you are able to be notified so that you can continue to follow us. And like the video, share the comments under the comment sections below so that we can continue to grow together. So as we begin, we want to look at depression. And by definition, depression is also a mental disorder. This is a mental disorder characterized by feelings. It is characterized by feelings of sadness, extreme sadness, hopelessness. Here you have lost hope, hopelessness, helplessness. You don't feel that there is someone who can even solve your problem. And as these feelings of mental disorder, as they continue, you lack pleasure or interest. These ones lead to lack of interest of daily activities. They lead to loss of interest for daily activities. So you find someone cannot even do what has been doing, and this one can even result into disturbances of sleep, lack of appetite. You find someone who used to eat so much is no longer eating due to depression, and so they are always holding their head in misery because of this depression. And this depression is triggered by many factors. The cause of depression can be, the most cause is increase. It is decrease, not increase. It is due to decrease in monoamine neurotransmitters. When there is a decrease in these monoamine neurotransmitters, like decrease in serotonin, that is 5-hydroxytryptamine, we can call it serotonin. If it is low in the neurons of the CNS or in the brain, if there is low norepinephrine and sometimes dopamine. So these monoamine neurotransmitters, whenever they are low in the cleft of CNS neurons, it can lead to depression. And another one can be hormonal changes. For example, in pregnancy, we can see depression coming in due to hormonal changes, and also due to physical factors like trauma. Maybe you have lost your friend. This one can lead into a depression. When you continuously think about the problems and you feel there is no help, you have lost hope. That's why even the Bible says there are only 3 things that can make someone to continue moving. That is love, faith, and hope. But above all is love. But even when you lose hope, you can lose yourself. So these people can think of even committing suicide after a long time. When not treated, they can think of committing suicide. And we are going to see that these neurotransmitters, how can we know the different mechanisms of action of these antidepressants? That if we have serotonin, that is the 5-hydroxytryptamine, we have neurotransmitter like norepinephrine. These ones are taken into the presynaptic cleft, and then they are always released due to entry of calcium by exocytosis into the synaptic cleft. These are the neurotransmitters released. That is 5-hydroxytryptamine, that is serotonin, and norepinephrine. And as we have said, it It is majorly due to low levels of serotonin or norepinephrine. So the therapeutic goal of all antidepressant drugs directly or indirectly act by increasing serotonin and norepinephrine levels in the synaptic cleft. So because of due to decrease in norepinephrine and decrease in serotonin causing depression. So the therapeutic goal of all antidepressant is to act by increasing serotonin levels in the cleft and increasing norepinephrine and sometimes dopamine in the synaptic cleft. And how can we increase is that when some of them will bind on their receptors, and some of them bind on the receptors, what we see, one of the mechanisms is to increase when the norepinephrine is low and we want to increase it, we can increase it by, because we know some of them are taken back into the presynaptic neuron, and after being taken up, the neurotransmitter, and this transporter is known as NAT, norepinephrine reuptake transporter into this, then this one is taken back into the cleft, into the vesicle, and can be brought back. But some of it is metabolized by MAO, monoamine oxidases. This MAO can metabolize this norepinephrine into active metabolite which can be excreted. Then if we want to increase serotonin, so if we want to increase norepinephrine, we can block this NAT. If we block this transporter that takes back the norepinephrine, we can increase the concentration in the synaptic cleft. And another way we can increase it is by, there is another transporter known as serotonin reuptake transporter here. So if we have serotonin in the cleft, it is taken back into the presynaptic neuron, and it can be taken back into the vesicle and brought back. Then some of it is metabolized into metabolite and excreted. So another way of increasing serotonin in the cleft is by blocking this transporter. If I have a drug that can sit here and block, it can increase. Another one which can sit here and block and increase. Then we can also have other drugs which can inhibit MAO. And if I don't metabolize serotonin and norepinephrine, meaning more of it will go back to the vesicle and is brought back, hence increasing the concentration in the cleft, so that we can increase their chances of binding on the receptors on the postsynaptic nerve. Then we are going to see other drugs that can block alpha-2 receptors, which are found presynaptically, and the drug of which targets this we shall see is mirtazapine. We'll be doing this. Then we are also going to see 5-hydroxyserotonin 2 receptor antagonist. Shall see serotonin 2 receptor antagonist, which we shall include trazodone will be one of the examples. So these are the mechanisms of action of antidepressant drugs, which we are going to discuss in all of this session. So we have looked at how depression comes in, what causes it, and now we are going to see the different mechanisms whereby we shall see those ones that only inhibit serotonin reuptake, those ones that inhibit both serotonin and norepinephrine reuptake, and those that inhibit MAO, those that inhibit serotonin receptors on postsynaptic neuron, and those ones that inhibit alpha-2 receptors. So we are going to look at one class one by one. And we want to begin with class one. We want to begin with is selective serotonin. Selective serotonin inhibitors, reuptake inhibitors, which we normally abbreviate as SSRIs. These are known as SSRIs. And these SSRIs, before we even give examples, these ones are drug of choice. These ones are drugs of choice. These are drugs of choice for drugs of choice for treatment of depression. So if you have someone with depression, the first line drugs we can use for people with depression is SSRIs, that is selective serotonin, and their mechanism of action is that for them they bind to serotonin reuptake transporters, and hence inhibiting, these guys inhibit reuptake of serotonin 5-hydroxytryptamine. And when we inhibit reuptake of this serotonin, then we increase its concentration in the synaptic cleft, hence binding to receptors to bring a response so that can treat depression. And examples of the drugs under SSRIs, we're going to see SSRIs include drugs like fluoxetine, drugs like paroxetine, we have drugs like staropram, we have staropram and sertraline. So these are the example of drugs found under SSRIs, that is selective serotonin reuptake inhibitors, which only inhibit reuptake of serotonin. And these ones, we have said they are drug of choice for treating depression because of their less side effects. But other indications apart from these drugs are indicated. The indications of these drugs, we can use them apart from treating depression. We can use them in treatment of other conditions like GAD, generalized anxiety disorder, post-traumatic anxiety disorder, We can see in premenopausal, premenstrual dysphoria. These are ladies, whenever they want to go to menses before they can get panic attacks. We can use these ones in the treatment of bulimia nervosa. Bulimia nervosa, this is overeating. That is bulimia nervosa. And the best drug for treating bulimia is fluoxetine. Fluoxetine is a drug of choice for people who eat much, who are overeating. Whenever you give them food, they want to eat until they feel like even vomiting. So every time they are eating, so it is a mental disorder which can be treated by fluoxetine, that is bulimia nervosa. Then the drug adverse reactions of this, we said they are minimal, but they are known to cause hyponatremia. They cause hyponatremia, that is decreased levels of sodium, especially in elderly. We see it causing sexual dysfunction. Sexual dysfunction is another cause. It can cause nausea and so forth. So these are some of the side effects. So they are minimal. Why? Because SSRIs, they are preferred because they do not, you can note this, that SSRIs, they have no anticholinergic effects. no anticholinergic effects, no antimuscarinic effects. They are not seen here, like dry mouth, constipation, urinary retention are not there, and even they don't, no sedation. So that's why we prefer them compared to others. They don't cause sedation. So this is what we can discuss under SSRIs. The next class we can look at, number 2, is SNRIs. SNRIs, that is serotonin norepinephrine reuptake transporter inhibitors. Serotonin, so meaning the mechanism of action of these drugs, for them they act, we saw SSRIs selectively inhibit serotonin, whereas these ones, for them they act by inhibiting, they inhibit both 5-hydroxytryptamine and norepinephrine reuptake. And whenever they are inhibited, we shall see increase of serotonin and increase of norepinephrine, hence solving the problem of depression. That is their mechanism of action. And examples of SNRIs drug, we have majorly SNRIs. We see drugs like duloxetine is one of the drug. Duloxetine. Another example is venlafaxine and desvenlafaxine. These are the drugs under serotonin norepinephrine reuptake inhibitors. And these drugs are indicated in conditions, we can use them to treat depression. They're indicated in treating depression. These ones can also treat chronic pain, treatment of chronic pain, like in people with diabetes neuropathy. And people with fibromyalgia. So people with chronic pain, we can also indicate this. We can also indicate this in people with anxiety, that is generalized anxiety disorders, and also obsessive compulsive disorders. We can also use these drugs. And the major side effect, that is adverse drug reactions with this drug, the major effects of these drugs, that they can cause sexual dysfunction, because of their minimal activity on alpha-1. They can cause QT prolongation sometimes, but not common. We can see it causing also hyponatremia. It can cause hypertension. And other GIT side effects. That is what we can talk about SNRIs. So, before we leave SNRIs and SSRIs, that another side effect they can bring is serotonin syndrome is another side effect. Then another side effect of SSRIs, they can lead to bleeding. These ones can also lead to bleeding. Why? Because they can inhibit serotonin in the platelet. Platelets also use serotonin in the action of preventing clotting. So in case you are taking much of SSRIs and SNRIs, majorly SSRIs can lead to bleeding due to inhibition of serotonin in the platelets. So these are what we can discuss under this. Then another class, that is number 3, is TCAs, tricyclic antidepressant. Tricyclic antidepressants, these ones, they have much side effect compared to SNRIs and SSRIs. So whenever someone is having depression, is not responding to SSRIs, is not responding to SNRIs, we can give them TCAs, though they have much side effects. And the mechanism of action of TCAs, these ones act by, they inhibit both serotonin, they inhibit norepinephrine and dopamine reuptake. So these ones inhibit a couple of them. And after inhibiting them, they increase their concentration in the cleft. And these TCAs are divided into 2, or they are classified into 2, whereby we have tertiary amines. And among the tertiary amines, we have drugs like amitriptyline, we have drugs like imipramine, we have drugs like trimethylene, we have other drugs in this category such as trimipramine, we have dosectin. These are the examples of tertiary amines which cross the central nervous system. Then other type of drugs we can see under this section is the secondary amines. We have also others like secondary amines. And the secondary amines under this category, we have nortriptyline and protriptyline. So these are the example of drugs we can give under tertiary amines. And their indications, because they have much side effects, remember, and they are not of choice, they are used when SNRIs and SSRIs have failed. So these drugs are indicated in treatment. Those are TCAs, can use them in treatment of depression when SSRIs have failed. We can indicate them in treatment of chronic pains, like in diabetes neuropathy. We can apply them. And we can also use these ones are used also in as anesthetic drugs and treatment of anxiety. So tricyclic antidepressants, they are also indicated in treatment of nocturnal enuresis. This is what we can call bedwetting. So if you have children who are failing to stop urinating on the bed, the drug of choice we can give them is imipramine. Imipramine can treat bedwetting. So in objectives, if they ask you which of the following drug is used for preventing bedwetting or nocturnal enuresis, that is imipramine, then we shall see even amitriptyline can be used in treatment of migraines prophylactically. So whenever someone has intermittent headache, we can always prophylactically give amitriptyline. So meaning another indication can be treatment of prophylaxis of migraine. So the peculiar things you have not to forget on the TCAs is that amitriptyline can treat migraines and imipramine can also treat bedwetting, which we are calling nocturnal enuresis. So if they bring it on objectives as a student, you should be able to answer this. That is very important. Then we saw fluoxetine treating bulimia nervosa, overeating. Don't forget that. Then the adverse reactions when using TCAs, apart from inhibiting these neurotransmitters, they also bind on muscarinic receptors, histamine receptors, and adrenergic receptors. And when they bind on first of all, these drugs they can lead to anxiety, or you can develop anxiety disorders. Another side effect they can bring about QT prolongation, QT prolongation can be a side effect on these drugs. They can lead to cardiac arrhythmias due to their action on alpha-1, meaning they can bring about orthostatic hypotension. Orthostatic hypotension due to their action on alpha-1. They can also cause extrapyramidal symptoms, which we saw as dystonia, akathisia, and so forth, due to their action in the CNS. And their action on muscarinic receptors can lead to dry mouth. Here we have, don't forget, sexual dysfunction, dry mouth, constipation, urinary retention. Urinary retention can be side effects, dry skin, xerostomia. All these are they are side effects when this drug acts on the muscarinic or anticholinergic receptors. So these are the side effects. And another thing we need to always know is that among the SSRIs, there is this drug citalopram and citalopram. These ones can also cause QT prolongation. So they can lead to cardiac arrhythmias. This one can also lead. So note it that citalopram can also do QT prolongation as TCAs when given. So these are the side effects we can discuss under TCAs. Another drug we can talk about, another class, number 4, is MAO. Monoamine inhibitors. And these monoamine inhibitors, they are categorized into two, whereby we have non-selective and MAO type B selective. And those ones which are non-selective, we are going to see examples like isocarbazide, carbazide. We are going to see phenarizine as examples. There is another one, tranylcypromide, cypромine. These are the examples of non-selective, meaning these ones bind both to MAO type A and type B. That's why we are calling them selective, which is different from MAO type B selective. Examples is sereglin and rasaglin. And these selective ones are majorly used in treatment of Parkinson's. These ones are indicated majorly in treatment of Parkinson's disease. Then the non-selective They are indicated in a couple of conditions, and examples of those conditions where we use this. For it, majorities, they are used in treatment of depression. These ones we can use in depression, though we are going to see major side effects caused by them. So these ones, the MAO inhibitors, their mechanism of action, they act by inhibiting MAO. And after inhibiting MAO, there is no degradation of norepinephrine and serotonin, hence increasing their concentration. That is their mechanism of action. Then the adverse reactions, the drug adverse reaction of MAO inhibitors, the ADRs, these ones can lead to cheese reactions. It can lead to serotonin syndrome. And another thing they can lead to, these MAO inhibitors, is that they can cause seizures. And cheese reaction is due to, in the intestines there is MAO, monoamine oxidase. So when people who are taking beer or wine contain tyramine, and this tyramine, whenever we inhibit MAO, meaning that it is not metabolized in the intestines, and it can reach the CNS, and when it reaches in the CNS, it can cause what we call hypertensive crisis. Hypertensive crisis, and when it leads to hypertensive crisis, this side effect brought about by this cheese reaction can be treated by giving phentoramine. Phentoramine can be indicated to treat cheese reactions on people who are taking alcoholic drinks when they are on MAO inhibitors, because MAO inhibits tyramine in the intestines, leading to hypertension. Then serotonin syndrome comes in when used together with SSRIs, because SSRIs are the one known to bring serotonin syndrome. So when you are giving MAO inhibitors, especially non-selective, and you immediately revert to MAO, to SSRIs, they can bring about serotonin syndrome. So it is advisable to use them after 14 days. So if someone has been on MAO and you want to give SSRIs because MAO has failed, you can wait for 14 days. Then seizures, there are also other conditions which is first due to MAO inhibitors and can be solved by giving MAO inhibitors together with pethidine. So when you give MAO with pethidine, you prevent these seizure-like symptoms from happening on these patients who are on MAO inhibitors. So this is the peculiar things we can discuss. No examples of non-selective which target both A and B type of MAO, and those which are selective, and the selective type we have seen majorly used in Parkinson's disease. This is what we can. And don't forget about cheese-like reactions under this category of drugs. Cheese-like reactions which leads to hypertensive crisis and can be treated using phentoramine. Very important to note. Then another class, number 5, we can talk about is bupropion. Bupropion is another class of drug which you have to know. And this bupropion, for it, its mechanism of action, it acts by inhibiting, it inhibits dopamine reuptake and norepinephrine reuptake. That is its mechanism of action. And this bupropion is also indicated in treatment. Apart from depression, it can be used to treat the treatment of cessation of smoking. If you want someone to stop smoking, the best drug you can use is bupropion. So as a student or as a practicing person, don't forget a drug of choice for stopping. If you have people who have failed to stop smoking, you can use bupropion. This bupropion can also be used. It has seen potential of precipitating, it can cause precipitation of seizures, so it can be used. And also people facing sexual dysfunction can be used. This is the indications we can use for bupropion. Then another class, as we are near to conclude, is the mirtazapine. Number 6 is mirtazapine. You can talk about mirtazapine. And mirtazapine, for its mechanism of action, it acts by antagonizing or inhibiting alpha-2 receptors found on the presynaptic, which, as we had seen it on the diagram, presynaptically, and when it inhibits the action of alpha-2, which is inhibitory, it enhances the release of norepinephrine. That is its mechanism of action, and it can also be indicated in treatment of depression. Then the last drug we can talk about is serotonin antagonist. Serotonin, that is a 5-hydroxytryptamine 2 receptor antagonist. And these drugs include, we have majorly 2, that is trazodone and nafazodone. And these ones can also be used in treatment of depression. And the side effect of these drugs, trazodone majorly we have nafazodone, which leads to hepatotoxicity. This one can lead to hepatotoxicity, whereas trazodone, for it can lead to what we call priapism. This one can lead to priapism, which is painful erection, painful prolonged erection. That is priapism. So whenever you are on trazodone, it is not good for boy child because they can lead to priapism. Then this one is not, it is contraindicated in people with liver diseases because they can induce hepatotoxicity. That is serotonin receptor antagonist, trazodone, and nafazodone. So this is what we can discuss under antidepressants, where we have seen majorly 4 classes. That is SSRIs, whereby SSRIs, we said they are the drug of choice due to minimal side effects. And another thing don't forget about SSRIs is fluoxetine being used in treatment of bulimia nervosa, overeating, then cytarabine and citalopram and exaccitalopram can cause QT prolongation, apart from other side effects like sexual dysfunction and bleeding. Then we have seen SNRIs. Whenever these ones fail, we can revert to SNRIs. This is the second choice. And these ones we have seen duloxetine, venlafaxine, and venlafaxine. And their major, we can see, apart from treating depression, we can use them in chronic pains, especially diabetic patients, and those ones with fibromyalgia. Then the adverse, we have seen major hypertension, hyponatremia, both of them, the serotonins, and then causing serotonin syndrome. Then TCAs, we said they are not of choice due to their much side effects, but when these 2 fail, we can revert to them, and we have seen they can also be used in treatment of depression. But the 2 peculiar things not to forget is that amitriptyline can also be used to treat intermittent migraine, that is migraine, prophylactically. Then bedwetting or nocturnal neuresis, that is for imipramine. Never forget those ones. Then we have also seen causing many side effects due to its activity on alpha-1, that is can cause orthostatic hypotension, on muscarinic receptors, dry mouth, constipation, urine retention. Then we have seen MAO inhibitors, both non-selective and selective, whereby the non-selective ones we have seen they can cause cheese reactions, then seizures, and these cheese reactions on alcoholic people can be treated using phentoramine because of its causing hypertensive crisis. Then ibupropion, not forgetting smoking cessation. These ones you can give them to chronic smokers. That is ibupropion, and even treatment of seizures and sexual dysfunction, don't forget that. Then mirtazapine majorly for also treating depression by binding to alpha-2. So if they ask you which of the antidepressant drugs act by inhibiting alpha-2 receptors presynaptically, that is mirtazapine. Then serotonin 2 receptor antagonist, we have seen trazodone and nafazodone, whereby trazodone, don't forget, they can cause priapism, painful prolonged erection in a boy child or in men. Then nafazodone, contraindicated in liver failure because of its hepatotoxicity. Thank you so much for listening from the beginning until the end. May God bless you.